Morning, everyone. It's 9:01. We're going to go ahead and get started. My name's Barry Nickerson, and this is the EMS Audit Review for April. We've got a pretty decent agenda today. Typically the same stuff, but we've got an extra run review that I'm going to do a presentation on at the end. So we're going to start out with the STEMI report. And the STEMI report actually comes from Brenda Williams, but she cannot be here today, so I told her that I would do the presentation. So we're going to get started. So you got your patient is. So you've got the dispatch is 1624 residents with a complaint of heart problems. At 1641, they arrive. 61-year-old female patient sitting in a chair, pale, cool, clammy. She started feeling bad about 30 minutes prior to arrival. Nauseous. Husband states she has vomited. Complaint of chest pain, middle of the chest, between her shoulder blades. Typical, right? A&O ×4, history of diabetes. 1643, 12-lead EKG, elevations in 2-3, AVF, and depressions in 1, AVL, and V2. 4 minutes later, the patient's ambulated to the cot and taken to the ambulance. Vital signs of time, 122/66. Got a 70 heart rate, 97% room air. Respirations are 20. Got 97.5 temp. Pain is a 6, and blood glucose is 123. At 1649, 2 minutes later, we're given aspirin, 324. Start an IV, 500 cycles and bolus started. Patient monitored throughout transport, no change in status, remained alert and conscious. Iron given to the ER. 1703, arrival at the ER, 12-lead repeated with no changes, taken to trauma 2. Arrival to the cath lab procedure at 1750. This one was really cool. I had called Brenda to talk to her about this. This patient would become significantly bradycardic every time they tried to introduce the wire, to the point where they actually had to put a transvenous pacemaker was inserted to prevent her from going to asystole and bradycardia during the procedure due to the patient becoming very bradycardic as a guide wire was introduced. Every time it went into the right artery, she would drop into the 20s and 30s. And so they actually put the pacer in. That was really kind of cool. Something new, something different. We haven't had one of these in our reports yet. Severe hypotension, which was treated on IV fluids and dopamine. At 1831, the balloon crossed the lesion. In 1841, a drug-eluting stent successfully deployed right distal artery lesion, reducing blockage from 85% to 0. Patient was transferred to ICU, discharged home 2 days later. Balloon to door time, 88 minutes. Just happened to make it under our limit there, right? So she wanted me to let you guys know that we are 100% right now for 2021. Through our chest pain accreditation, I have a bad feeling these door to balloon times they're wanting to drop them from 90 down, 90 down, 90 down. So that may come into play for us EMS personnel out in the field to help fix that problem. But as of right now, we're 100% across the board for everybody bringing in STEMIs. She wanted me to be sure and tell you thank you for all you do. Any questions about the STEMI report? All right, so we're going to move on to our primary stroke center. Our EMS case, and Beth Harrison is going to present for us for that. You can put that on, or you can talk about it.
Okay.
Let me turn it on. Put the button in front. Thanks, Beth.
Thank you. Hello, everyone. As Barry alluded to, dropping down the time for the STEMIs, we just got word this last month that HVAP has decreased our door-to-needle time for TPA administrations. So that's going to be a big change for our stroke program. And so more to come on that at a later date. But this is an interesting patient. It's a 67-year-old, actually it's a male, I put female here, it's actually male, whose last known well was 2/23/21. Oh, sorry. And that is Central Time. He was found in Illinois. He was traveling from Arizona to New Jersey by himself. He pulled off the highway at a gas station and became unresponsive. And the employees at the gas station found him, called EMS. They were notified at 15:17 Central Time, and they arrived at 15:25. He arrived here at Union at 17:01 Eastern Time, so 5 p.m. Indiana time. And EMS did call ahead to the ER with a stroke alert. When EMS arrived at the gas station with this patient, they found the patient was responding, but very confused. They were complaining of a headache to the right side of his head and shortness of breath. They did not do a Cincinnati pre-hospital stroke scale or a Van scale. They actually did FAST. And with the FAST, they found he had left facial droop, left arm drift, and left leg weakness. The patient was brought to Union and went directly to the CT scanner. At 17:04, our neurohospitalist was in ER, and the CT was completed at 17:22 and was negative for a bleed. TPA was administered at 17:27, and they had a door to needle time of 24 minutes. We did not do a CTA or a CTP on this patient because it was not indicated, because his NIH scale was less than 6. Actually, it was right at 6. Through his course of treatment, they did do an MRI, and he was found to have a distal right MCA stroke. He had a prior medical history of an LV thrombus that he had stopped taking Xarelto for in January of 2021. As they completed the stroke workup, they did a carotid Doppler, which showed a possible carotid dissection. And they did do a carotid angiogram. And it was completed and did not show dissection, but he was in definite need for an endarterectomy. And through that, they found that the stroke was likely cardioembolic, and he was started on some thinners before he was sent on here. I think they put him back on Xarelto. The good news for this patient was he was discharged after the TPA with an NIH of 0. So he totally recovered from the stroke. He had no need of physical therapy, and he was released that day after his cardiac cath, and he is going to follow up with his physician in Arizona for his carotid surgery, and he continued on to New Jersey, but his wife was driving. Our highlights and our opportunities for improvement with this: a stroke alert was called, but a Van scale was not completed, and the Cincinnati stroke scale was not completed. You know, those are our standards. I'm very glad they did the FAST and it did show his weaknesses, but it could have been a different outcome had his blockage been less distal in the MCA. We probably would have been sending this patient to Indianapolis for a thrombectomy. And the really good news is his TPA was administered in 24 minutes. And that's one reason we had such a great outcome. So it was a really good job with this. They did recognize all of his symptoms, got him here very quickly, and we were able to do that. And if you guys have any questions about stroke, please let me know. Thank you.
Thanks, Beth.
Thank you.
All right, guys, moving on. Jackie's going to do her trauma report.
Yes, I'm loud-mouthing right there.
I'm with you.
All right, I have a loud mouth, so I'm pretty sure everybody can hear me. So Barry and I are going to do things a little bit different this time. So I typically present 2 cases. So let me back up and tell you, I had the cases picked prior to our trauma verification, and you're going to sense a theme here. We have been told that we are not holding EMS accountable for some of the things that could have been improved. So remember I said I had these charts picked prior to, plus a couple of you have gone to Barry and like, hey, what can we learn? Where are the opportunities to learn? So I was raised in the world of EMS when you literally got chewed up and spit out at audit and review. And I wanted to make sure that I don't do that. But these 2 cases were so blatantly obvious that we had opportunities to learn. I will tell you, this is the lesser of the 2. The one that Barry's going to review later, I think we'll have a whole lot more discussion on. So this was a situation, this was a bad situation. So let me just remind you that we are the rescuers, okay? You pre-hospital, us in the hospital, we are the ones that have to keep it together. If we lose it, people see us lose it, whether it's other rescuers, whether it's family, whether it's bystanders, and then the situation naturally escalates to what was already chaos and now becomes uncontrolled chaos. So this is a house fire. This was a very bad house fire. There were 5 victims, 2 fatalities. So this particular burn victim, so the original dispatch goes out at 1:44 in the morning. So not only is this a bad situation, but it got you up out of a dead sleep. They are en route at 1:54, on scene at 2:10, leave scene at 2:29, and here at Union at 2:46. So this was not a local run. So those are actually very, very good times. So 911 call to getting on scene was about 10 minutes. They were on scene for about 16 minutes. Again, it's already chaos. It's already frantic. It's a fully involved house fire. There are 3 victims out of the house, 2 still in the house. The 2 in the house did die. So 911 call to arrival here in ER is 62 minutes, and that actually is a good time. One of the other things that our trauma people got us for is your scene time. So yes, I took it for you, 20 minutes. If you are on scene longer than 20 minutes, I need to know why. And I send probably a dozen of these to Barry a month going, hey, can you tell me why? I don't seem to find a reason why. It happens. You're extricating. You had to do a difficult airway. You stopped to do an IV and pain meds. Whatever the reason is, you need to tell us because you're not telling us. So this particular victim is a 26-year-old female. She happened to be the mom. She's in a structure fire. She runs to you guys. She has burns to her hands and feet. You know you're dispatched to a structure fire. You know there's entrapment. You're met by the patient who has 2 children walking towards you. The one's 3 and one's 6, I think. Yes, Tori tells me yes. Mom screaming that her infant or boyfriend are still inside the house. Yes, the infant is just a few weeks old, and yes, the boyfriend is still inside the house. The 2 children were placed into one ambulance, and then it says the mom was placed into a second ambulance for her burns to be wrapped. I will tell you, of course, remember, I'm a Monday morning quarterback. Of the 3, the mom was not the most serious. One of the children was. Mom had 2nd-degree burns to both of her hands and her left foot. Her hair was burned, red flag number 1. Stated her head and neck were not hurting, red flag number 2, because we know when burns don't hurt, that's bad. Patient had soot around her mouth, but was able to maintain her own airway. Red flag number 3, soot around her mouth. So she's maintaining her airway right now, but we know from EMS 101, EMS 101, that it's not going to stay that way. Hang on, technical difficulty. We may not be sharing. Okay, hopefully you guys can see that. Okay, so her hands and feet were wrapped in clean, dry, sterile dressings. Kudos to you for doing that. And in the detailed findings, it tells me that her face is normal pain. So I'm assuming that means no pain. I honestly don't know what that means. There are burns and there are redness. Her face is burned. She has soot around her airway. Pupils reacted bilaterally. On her feet, she has burns, redness, blistering, charring, pain normal. So I'm assuming that means no pain. She has blistering and charring. She has no pain because she's burned. Her left hand, palmar and dorsal, are burned. Palms and the bottom of your feet are automatic transfers for us because of the vessels that are in them. She's burned, she's charred, she's blistered, she's red, and I'm assuming again, no pain. Right hand, palm, dorsal, burned, charred, blistered, red, no pain.
The only thing I can think of that could mean for this situation, her pain is normal.
Yeah, I'm not sure. It just says pain normal.
Yeah,
Yeah, it's just really gray, which means we have a lot of room for us to interpret that. And when you're writing a run sheet, I shouldn't be able to interpret. I should be able to read it and go, oh, okay. She complained of burns to her hands and feet. Says her primary symptoms were hyperventilation. Okay, she had soot around her airway. She had charring. Her hair had been burned. It says other symptoms, pain unspecified. Procedures was burn care. And you gave her oxygen via non-rebreather. Yes, good. Okay. Vitals were actually not too shabby. 156 over 72 at 215. SATs are 95. That should have told you right there. She's a young, healthy mom that just came out of a house fire. And at 237, they're still at 96. So she is holding them right now, but we know that eventually that's not going to stay there. So ED did call this a level 1 trauma activation, multiple burns, soot present in the airway, lungs had stridor. The IHERN was not called until 1 minute out. We have 3 victims from a multiple casualty incident, and we did not know it until you were 1 minute out. So the ED provider notes that it was a difficult intubation because she had soot in her airway and the edema was already starting to set in. Patient was transferred ground ALS to Eskenazi from our facility where she spent several days before she was discharged. She did have acute respiratory failure, multiple burns. The boyfriend and the baby did die in the fire. We later learned that CPS and PD became heavily involved in this, and I mean heavily involved in this. And I will just flat out tell you, she admitted to somebody that she set it on fire. She set the house on fire with the intentions of killing the boyfriend and all the children. So the times were good. Your times were really good. Okay. You recognized very quickly that it was a critical situation. Why didn't you do a scene flight? Okay. If nothing else, the little girl should have went by air. She spent weeks at Riley. She is still in Riley's rehab unit. She was the most critically burned. Why us? Why didn't you go to Paris? And so you can maybe argue with me that we're the trauma center, but that's not what it says to do. Your protocol says to the highest level of care. It is not a secret we do not keep burn patients. It is not a secret that we do not keep pediatric patients. These guys needed to be at Eskenazi and Riley. So either a scene flight would have been warranted, or maybe even to Paris, which was half the transport time, who could have airlifted them out as well. They can still stabilize. The IHERN was not called until you were 1 minute out. I had one doc that had to scramble for help. There was no, huh? And that was their times to be lowest staffing, Tori said. So they didn't even have as many nurses and techs at that time because we were at that middle of the night point. There was no notification of a multi-casualty incident until you got here. We get an IHERN 1 minute out. And then when you get here, it's like, oh, by the way, there's another ambulance right behind us with 2 children in it and 2 people died on scene. The narrative's pretty nondescript. It's very gray. It leaves a whole lot of room for interpretation, which is not what you want to do when you're painting that picture. And why no airway concern? That one really kind of bothers me as a used to be EMS and now living in the world of trauma. That one bothers me because the red flags were there. So I wish you were here so we could have a discussion on this. I think the discussion would be very robust. I think it would be very good. So one, don't hesitate to make the scene flight or go to the nearest facility because the rule says highest level of care, and the highest level of care for this situation would have been the burn center. Call us. Huh?
Email me or you if they have questions.
Yeah, Barry said you can email me or him, either one of us, if you have questions, comments, concerns, if maybe you can shed a little light on this to help us understand it a little bit better. That IHERN should have been called a little bit before that, or maybe an incident commander. Hope and pray there was an incident commander on scene. There should have at least been a fire commander on scene or a police officer or somebody that could have called the bat phone, could have called dispatch, could have called somebody and said, hey, give them a heads up. We're on our way with 3 victims. 2 people died in the house. Narrative is very nondescript. You need to paint a picture. And that was one of the things that the trauma people nailed us on. They said, they did look at your runs. We had specific cases that they looked at, and they need to be able to read that narrative from beginning to end and literally be able to tell you everything that happened on scene. And the airway, you got to think airway with burns. You've got to. She had singed hair. She had soot around her mouth. She had blistering and charring. Airway. So.
And I don't know, in the defense of them, I don't know if in their protocols RSI is available because I don't believe it is.
So that's would have been another reason to go to the local, the closest hospital to get airway, to maintain the airway. Yeah. The children did not have to be intubated. Oh, I'm sorry. The little girl did. She did get intubated. The little boy did not. He did the best of all of them. It was just a bad situation. It was just a bad all the way around. He kept telling people his sister was sleeping on top of him. And what we learned was that she was in a top bunk. He was in a bottom bunk. He had crawled under the mattress. The mattress actually saved his life. He spent 2 days, 3 days, minimal. He was treated basically, and 3 days later, he now is in the custody of one of the grandmas in Florida. The little girl was a whole lot worse. Like, they didn't think she was going to survive. She came through it. She got through the biggest part of this, and now she's got that long-term burn care rehab that she's going to have to go to. Mom was pretty easily treated and released once that airway was managed. She's not in the picture anymore. I don't know the legal situation. I haven't gotten back into the chart. So. Okay, I think it's Jimmy's turn.
Thanks a lot, Jackie. Appreciate and we do need to be held accountable, all of us. We also, when I do my presentation, there's some red flags too in that run. And so the best way to learn from things is whether it's a great run or it's a bad run, we learn from them. And that's what we're going to do. Next to present, Jimmy McCann is going to present on ABGs and ventilator management. And at some point in time, he's going to scream at me, and I'm going to move a whiteboard in place, and he's going to turn this camera around because we still don't have the big camera working yet. So you guys can maybe watch him do his work on the whiteboard on top of what we're doing. So next up is Jimmy. If you need to put this on, you can, or talk loud.
Okay, cool.
Whatever you need.
Thanks, Jimmy. Yeah, thanks. All right, so I'll put this on. So my name is Jimmy McCann, a respiratory therapy manager here at the hospital over pulmonary and cardiac rehab and fitness center. And I was asked to come today to speak about arterial blood gases and ventilator management. So I'm going to try to make this to relate to the EMS world as much as I can. And so try to bring examples into that. This is a very similar presentation that I give to the nursing programs here in town, and also physician assistants and other medical professions. So arterial blood gases are one of those things that if you don't stay up with them, you could actually lose that bit of knowledge if you're not looking at them all the time. So I encourage people that once they do learn to do arterial blood gases, to interpret them and to know the possible treatments for them, that you continue to look at them every 6 months or year, whatever it is, so you don't lose that skill, because it's very important in emergency management type situations. So first thing is, why do I need to know this? So that is a really good question, because you're not going to do a blood gas via ISTAT, and the EMS would not be really cool if you could. But it's really important to know what's going on inside the body and how the body reacts to changes in the acid-base balance within it. So as far as the kidneys or the breathing aspect, it's really good to know that the vital signs you're taking are a trend of what's going on deep down inside. And so sometimes we tend to overlook those things as far as vital signs go, specifically respiratory rate, and I'll speak to that here soon. But it's one of the very first indicators of a messed up acid-base balance, specific acidosis of any type inside the body. So it's really important to know about this. Now, I might go a little more in depth on what you're used to, but I'll try to make it relatable. So what is normal? So our normal blood gases, I put them on the screen. Of course, this is the first aspect of knowing how to read a blood gas. Now, why do I need to know how to read it? I've already taken my national registry and blah, 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 and all this other stuff. I get it, but it's really good to know how to read it. So these are the normal values: pH 7.35, CO2 is 35 to 4, sorry, pH 7.35, 7.45, CO2 35 to 45 millimeters of mercury. One of the keys I always like to say is that remember that CO2 is a pressure. It's not a volume. We're looking at bicarb, looking at volume, but this is a pressure, and what that pressure is actually based off of, and this is a whole nother talk, but it's based off of barometric pressure. So the pressure in the air around us, which we know at sea level is 760. So we're taking a fraction of those pressures, especially down inside of our arterial bloodstream, and that's what the PaCO2 stands for, partial pressure of arterial CO2. We're looking at the pressure related to that, not the volume. So that's why it can go way above 100 in most of these cases. So PaO2, I put it on every blood gas. I won't talk about that specifically today, but I highlighted in yellow because that is on every blood gas, but it has nothing to do with acid-base balance. It's purely looking at the amount of extra oxygen that we have available. I put a star next to it too, and we'll talk about that in a second. So, and then bicarb, 22 to 26 is what we consider normal arterial bicarb. So we need to know these, specifically the 3 white values and then the yellow values for oxygenation. The next part is memorizing which aspect of each of these values cause acidosis or alkalosis. So this is the first time I'm doing this on a screen. Usually I'll be writing all this stuff down. So it's kind of cool to use these arrows. We know that a pH below 7.35 is acidosis, above 7.45 is alkalosis. A CO2 below 35 causes an alkalosis, and a CO2 greater than 45 causes acidosis. Well, we know we've seen patients that have respiratory alkalosis, and in some of those cases, they're hyperventilating. So when they hyperventilate, they get rid of more CO2 than they should. And so the body will start to compensate for that over time. So think about hyperventilation causing the alkalosis and blowing off more CO2. And then the one we're most familiar with is acidosis related to hypoventilation, so not ventilating well, so the CO2 is building up in their system, causing acidosis, one of the most common ones we have to fix. PaO2, really important. Anytime a PaO2 level is reported, it has to be reported with the FiO2. A PaO2 level by itself means absolutely nothing. It has to be reported with how much available oxygen is in the alveoli, which comes from the FiO2. So just so on room air, we say 100 to 80 is normal, because available in the alveoli at room air at sea level is about 104 millimeters of mercury is available in the alveoli. Now, if we put somebody on a non-rebreather, that changes the whole game. So we take, and we're the normal PaO2 on non-rebreather. If somebody has normally functioning lungs where the AC membrane, alveolar capillary membrane is everything's diffusing across, it's usually around 600. So if they should have about 600 PaO2 on a non-rebreather. If they have a 100 PaO2, so you bring the patient a non-rebreather, we draw a blood gas on a non-rebreather, comes back and they have let's even say 150 PaO2. That's a problem. That's a major shunt. And if you have inside of your alveoli 600 and you only have 150 coming across into the arterial system, you have a problem. They have an oxygenation problem off the bat. So just because we would look at it and say, well, that's normal. No, that's not normal for the FiO2 that we're delivering. That's a fraction of inspired oxygen. I think you guys are pretty good with that. So, and then for bicarb, below 22 is an acidosis and above 26 is an alkalosis. Now, the next part is naming a blood gas. So I'll go through this a little bit fast, but the important aspects of naming a blood gas, we name them backwards. So if we're looking at some values, we're going to start with acidosis and alkalosis on the far right, and then we're going to name it backwards. So we're going to go respiratory metabolic next. And then the last aspect is we're going to talk about compensation of those. And the thing you should know, the only way to be fully compensated is to have a normal pH. So these are going to be some of those situations, and I'll have to give one of those examples on the board because I don't have one available today. But this is our fully compensated, maybe say respiratory acidosis, is our COPD patient with some kind of obstructive disorder on a good day. Body is doing exactly what it's supposed to do. So let's go look at an example first. So anytime you see a blood gas, we're always going to put slashes between it. And this is kind of an old shorthand type of thing. But if you see 4 numbers with slashes between them, we're going to be looking at pH, CO2, PO2, and bicarb. Remember the 80 for the PaO2 we're not going to deal with right now. So we're just going to throw that out. So what we're going to go through is each one of these, and we're going to call the 725 acidosis, alkalosis are normal. The 55 acidosis, alkalosis are normal, and the 24 acidosis, alkalosis are normal. So the next slide should somewhat do that. So I put the graphic there, and so 7.25 is acidosis, 755 CO2 is acidosis, and our 24 for a bicarb, these are made up numbers, but they work, is normal. So in this case, we have to name this blood gas. So naming the blood gas, what we're going to do is we're going to take, if this works. Oh, can you go back? Previous. Okay, cool. So what we're going to do with this, we're going to name the blood gas by saying whatever the pH is on here, in this case acidosis, that's going to go on the far right. The next thing we have to look at is who do we blame it on? So we're looking at our blood gas at the top. The far right is going to be acidosis for sure, because that's what the pH says. Now we're moving to the left and we have respiratory and metabolic. Well, there's 2 different other numbers we're looking at. We're looking at PaCO2 and we're looking at bicarb. Well, PaCO2 we know is ventilation. And those 2 terms should be absolutely synonymous. If you ever talk about somebody's PaCO2, you're talking about ventilation. If you're ever talking every single time. So PaCO2 ventilation. It's not oxygenation, it's ventilation, it's getting air out. So PaCO2 is respiratory and bicarb is the metabolic aspect of it. So in this case, we have to look at, we have acidosis and we go to the left and we say, which one of these systems do we blame for that problem? So which one of these systems matches what our current state is? In this case, 55 CO2 is acidotic too. So we say both of those are acidotic. So respiratory acidosis, that's pretty easy. And then we go down to our final one. And our final one, we have to ask ourselves, is the body doing what it's supposed to do? Is the side that's having problems, the respiratory side, getting assistance from the other side of the equation? Now, we know bicarb's controlled by filtering of hydrogen from the kidneys. So are the kidneys and the metabolic system helping in this situation? So how would we know if it was helping? If it has moved from normal values. So in this case, we know that our bicarb at the top is 24. That's right in the middle. We can't say it's moved. We can't say that this is something that's been happening for a while, or that bicarb's even that the kidneys are even trying to help at all. So in this case, this would be uncompensated. We're getting no help from the other side. And so this is an uncompensated respiratory acidosis. A couple things that you know about this. This has not been going, this is what I would consider an acute problem. This has happened fast. The cool thing about the body is CO2 moves really quickly and bicarb moves really slowly to catch up. Thank goodness we weren't made to have both of them move quickly, because we would be all over the place. One would be shooting up and back and forth. So bicarb moves very slow. The filtering of hydrogen is very slow. So what's happened is this patient is not ventilating well. CO2 is rising, and now slowly over time, the bicarb is going to slowly come up into an alkalonic state, and then offset the total pH. That's what the body's supposed to do. So we would say this is an acute problem right now. Okay, so acute respiratory failure, absolutely diagnosed, because we know that it's happened fast. We haven't got any reaction from the metabolic side yet. All right, so some more examples that we have of blood gas issues. So I put this on the board just so I can show a couple more with the screen, and then I'll come back. So I'm gonna have Barry turn this thing here.
If somebody could let me or Jackie or somebody know that you can see Jimmy and his board, I would really appreciate that. Jimmy and his whiteboard. Probably about as close as I can.
Yeah, that's all good. Yeah. Cool. So let's do it. We'll do a couple more of them. So you'll see that you'll have the screen there, and then you can see me on the video. So let's do. Okay, so we have a pretty bad blood gas here. These are numbers are made up, so you'll get the point, but they won't always just come out perfect. So let's look through this: 7.15, 25, 90, and 15. So
all we can see is the slideshow still.
They said they can't see Jimmy.
That's because we're sharing.
Oh, that's okay. If we can't do that part, this part is okay. I can kind of talk through it.
Okay, yeah, that makes sense then, because
Yeah, that makes sense.
if we're still sharing the screen, if we're not,
The camera's not. Yeah.
yeah.
Okay. I'll just do this one and then we'll go back.
Okay.
It's all good. I'll just talk through it. So act like you see me right now. Picture this in your head. Short, fat, bald guy, right? My head's shining. Okay. So 7.15, CO2 of 25, PO2 of 90, and a bicarb of 15. So we look at this 7.15 is acidosis. The 25 CO2 is below normal, so that's alkalosis. PaO2 of 90, we're going to call it normal. We don't know what FiO2 they're on. I'm not really worried about it right now. And then our bicarb of 15 is acidosis. So we are going to name this backwards. As we looked at our screen up here, we're going to name backwards. So whatever the pH says is what we're going to go with first. So that's acidosis. And then we got to figure out, as we're moving to the left, which one we're going to blame it on. In this case, the respiratory is alkalotic, the metabolic is acidotic. So we're going to call this metabolic acidosis. And then now we got to think, are we getting help from the other system? So is the other system moving appropriately to try to help out our problem? In this case, we're going to say yes, because the respiratory system's helping. Is it helping enough? So we look at the screen here. We have options are uncompensated, partially compensated, or fully compensated. We know to be fully compensated, you have to have normal pH, and this is not a normal day. So this is not a normal pH. So we're going to say partially compensated. So the body's doing what it's supposed to do. partially compensated metabolic acidosis. So with that, we think about, okay, we show up to see this patient. Some of the first things that we're going to see is you're probably going to have a patient who's tachypnic right off the bat. And are they tachypnic for no reason? In this case, because of this acidosis, they're breathing that fast because their brain stim's telling them to breathe that fast. The body's natural reaction, if you get nothing from this, this is what you should get. The body's natural reaction to any type of acidosis is to breathe fast. So anytime a patient has a higher than normal respiratory rate, it's really important to assess if they have an acidosis. Now, in this case, metabolic acidosis, that's kind of the ones that are a little bit more hidden. There's three big ones that we look for with metabolic acidosis. Number one is DKA. Now, Kussmaul's respirations, you know, all that kind of stuff. Fast, deep, breathing that fast to try to offset that acidosis. DKA is the first one. The second one, which is very common in this community, is renal failure. So if they have a history of renal failure, it's as maybe they've missed their dialysis or whatever it would be. How is that going to show up? Well, it's going to show up in their respiratory rate first. So if there is any possibility that when you show up to a scene, especially if you're going to an extended care facility or something, if they have done good vital signs and they have a trend over the last day of respiratory rate, it's really important to look at that because respiratory rate is going to increase. It's telling you what's going on down inside your system. So it tells you there's an acidosis of some kind. So that's renal failure. And then the third one is sepsis. So a septic patient, as sepsis progresses, you release lactic acid. It's going to cause the same metabolic acidosis, and the respiratory rate is going to increase. It's one of those vital signs that we kind of overlook a lot, but it is very important to assess and to have a trend of it, because one respiratory rate means nothing. I need to have a trend of those respiratory rates. So let's move on to a little bit of other stuff here as far as ventilator modes. How's my time, Barry?
Oh, you're doing great.
Okay.
It's all you, everyone.
Don't say that. Cuts me out. All right, so let's talk a little bit about, we talked about blood gases. Now we're going to shift gears slightly to, no, I don't think so. We're going to shift gears slightly to ventilator modes. So because we talked about CO2 being our problem, and we need to ventilate the patient, that's how we put them on a ventilator. And I don't know if it's one of your guys' pet peeves. I've tried to get away from pet peeves, but I still, the whole respirator ventilator thing is very interesting because I know respiration actually takes place at the cellular level, and we can't do that. And I wish we could, because the whole COVID thing would have been pretty easy to take care of. But we put people on ventilators because we look to get air out of their lungs, and we can control CO2. So first of all, look at our.
Right. Keep going.
Yeah.
Just want to fix something.
Yeah, no problem. There we go. Oh. There we go.
Yeah, it just dawned on me.
That's okay. It's all good.
Remember when I shut the video off there?
Oh,
Now we have video. Okay, cool. Now you see me. I'm sorry. Sorry about that.
No, that's my fault.
Yeah, no, it's okay. So I'm sorry that they see me. That's the only thing, yeah. So anyway, so let's look at our ventilator modes. So we have three big ones we're going to talk about. And I do get that, you know, you're not going to be able to go really in depth in this ventilator weaning and whatnot in the field, but it's really important to know these in case somebody would ask, and plus just for furthering of your knowledge. So the three big ones we look at are assist control, SIMV, synchronized intermittent mandatory ventilation, and CPAP and pressure support. So this is kind of the full support mode, as you could call it, assist control, going down to patients breathing spontaneously. So I always like, if a patient or family asks about the mode that they're in and they're in assist control, I always call it the resting mode. So one of the important aspects of assist control is, there we go. It's got three settings. So assist control has three settings. We know it has tidal volume, respiratory rate, PEEP. Every one of these has FiO2, which is really important, but I'm not going to address it in this case. So we're looking at ventilation. So with assist control, we know that every breath is finished. So if the patient doesn't take a breath, they get a set volume. So let's say in this case, they're 500 ml, so we have set. So they're going to get 500 ml X number of times per minute, what our respiratory rate is. But if the patient takes their own breath or starts a breath, they're going to get 500. Every time they start a breath, they get 500. Yes, you can hyperventilate a patient with this, because if they are taking a lot of breaths really rapidly, it's going to finish every breath of theirs. But our goal with assist control is to take that work off the body so that we give them a volume each time. Now, years ago, they used to have something called control mode, which was not assist control, which was you get 12 500s per minute, and we're going to block you out if you try to take a breath. Well, we live in the world of rainbows and unicorns now. No, it doesn't really have anything to do with that, but we allow the patient to take their own breath to start it, but we finish it every time. That's why I call it resting. Just because they're in assist control doesn't mean we can't extubate in the next 5 minutes. It's very common these days to keep our patients on assist control, wake them up, have them follow commands, put them on CPAP and pressure support for 5 minutes or not even at all, and then extubate them. Because just because somebody's on this doesn't mean they can't breathe spontaneously, because they can. We're just finishing the breath for them, especially if they're a really short vent stay. We know that they didn't have muscle atrophy in that one day that they were on a vent. Now, if they were on for 15 days, it's a different story. But assist control, as much as it sounds like we're taking full control of them, yeah, we are, because we want to make sure the acid-base balance is controlled, but we also can wake patients up on this. They can respond as long as they remain calm. One thing that you will find, the patient can become tachypneic. They can become tachypneic on any vent mode, and I'll say that in a second. But in these cases, if they're tachypneic, we try to find the problem. Is it a mucus problem, or is it an anxiety problem? The good thing is you can give them medication for the anxiety, for the pain, and you still have that assist control mode to give them breaths. So, or you could paralyze them. So if they're paralyzed also, this is the mode they should be in, assist control. So if you have a patient that's paralyzed and they're in assist control, but they're taking, let's say you have 12 breaths per minute set, but they're taking 20 breaths per minute, you want to look into your flows that you're delivering, if you can, or the trigger that's going on, because there are different things. Like if you have a large, not to be graphic, but a large chunk of mucus in the airways, it actually can manipulate flows enough to trigger a breath. So if they are breathing higher than what you have set and they're paralyzed, look into a mechanical type of issue as far as anywhere from their airways up through the ventilator to make sure there's not a leak somewhere in the vent, but they shouldn't be breathing more if they're paralyzed. So, but we see it quite often with things. And then each breath is given a set time of volume. So complete control of the ventilation so that the patient can quote unquote rest. So SIMV, this is the next level down. So we have tidal volume respiratory peep, same thing as we had with assist control. And then with SIMV, we add pressure support in. So this is, we're going to give them so many breaths per minute. We're going to give them these really nice breaths. But if they take their own breath, we're going to make them do a little bit of work. So if they take their own breath, they get a little bit of help, which is the pressure support. What pressure support is, pressure support is given for spontaneous breaths. So we have, let's say, 10 ventilator breaths per minute and then 3 spontaneous breaths. Those 3, the ventilator will sense that and give them pressure support. So they have to work a little bit. This is more of the working mode. I think I get into this in a second, but this is a little bit more of the working mode. They can become tachypneic. And we know that if a patient's on a ventilator or a patient's breathing spontaneously, we know if they get tachypneic and shallow, that's when they're failing. So they'll do the exact same thing on a ventilator that they would do if they were right in front of us breathing. So if they start getting tachypneic and shallow, they're starting to fail and not able to maintain their own ventilatory needs. So SIMV is, we're giving them the set breath, and then we're also giving them a little bit of help. So, and then it allows the patient to breathe spontaneously and also have a safety net. So we can, you can breathe a little bit on your own, and then if they stop breathing, we still have those backup breaths that they can do. And then the last mode is really them breathing spontaneously, but we took away tidal volume, we took away respiratory rate. We're giving them PEEP, which is good anytime you pass the past the glottis. Kind of interesting, actually. We all have what's called anatomical PEEP. So we have about 5 centimeters of anatomical PEEP, and it's maintained in our airways because of our the glottis that's closed and how we breathe. We maintain 5. When you take an endotracheal tube and bypass that, you take the anatomical PEEP away. So that's why we've always in the past just given 5 a PEEP, because you're just giving it back to them. And what that does, it helps keep alveoli recruited during this. Now, if we go in and put 0 PEEP on them, yeah, we're going to get some atelectasis in places because we're bypassing the glottis. So you have the PEEP we're given, which is pretty standard, and then our pressure support, which is just helping the patient to overcome the circuit resistance and resistance to the ET. So what do we need to know with this? This is to assess their respiratory drive before extubation. The patient also can become tachypneic, as they can in these cases. So we need to, if they become tachypneic and shallow, they're failing, we put them back on a rate. That's the way we wean them. And then maybe try them the next day, rest them for a little bit longer. Make sure the tidal volumes are adequate. So what tidal volumes we're looking for? Our goal is really 8 milliliters per kilogram ideal body weight, or you're really 8 to 12. We used to shoot for 10. Now we're more of like 8 mLs. So generically 500, 600, 700. That's kind of where we're looking for exhale tidal volumes. Those are really important when they're on CPAP and pressure support, because somebody can have a normal respiratory rate, but you have to look at volume because those two things are really important. All right, and then the next one I'm going to go to is looking at arterial blood gases and changing ventilator settings. So this is bringing both of those aspects together to kind of talk about how we change settings for specific blood gases. So let's look at our first blood gas. So we have 7.25, 52, 80, and 23. So we look at that. That is an uncompensated respiratory acidosis, normal oxygenation. And this is our current ventilator settings we'd have the patient on. Well, right off the bat, we're not ventilating the way we should. So you see I have an AC rate of 12, it says control, 600 milliliters tidal volume. That's 8 milliliters per kilogram. Just give me a ballpark of what it is. 10 of PEEP, 50% FiO2. And the patient values, the respiratory rate of 12. Exhale tidal volume is very important. So I don't care how much you give, you gotta look at how much is coming out. If anybody ever asks you which tidal volume is more important, sounds like Dr. Timbrake might ask, but whatever tidal volume is more important, it is always exhale tidal volume, or maybe you can ask him that. That'd be a good one. I wouldn't recommend that. Never mind. Yeah, don't do that. Maybe do it right before you gotta leave. So exhale tidal volume is way more important than regular delivered tidal volume. And then our PEEP of 10. So what would we change? Well, looks pretty easy at this point. We're like, they're not ventilating. We're going to change their respiratory rate. So what do you change it to? Well, usually we just kind of ballpark 12, let's go to 14, or let's go to 16. I don't know why it's always even, but it's always even. I don't know. So, but it's kind of interesting because some anesthesiologists don't change it to an even number just to kind of mess with our head a little bit. But there is actually a formula that we can look at, and I don't want to overload, but there's a cool formula. It's one of my favorites, one of my top 5 favorite formulas that we can look at for changing ventilator modes. And this works. It's really cool. So what it is, minute ventilation is respiratory rate times tidal volume. So those two aspects together, are the best indicator for somebody's ventilation. So we take their minute ventilation and their CO2 that they have, and then we take their minute ventilation and CO2 that we want, and we solve for X. So sorry, I said solve for X. You probably just totally zoned out at that point. So if I look at this, we have 600 times 12. That's what we currently are, times the 52, which is our CO2. And what do we want? We want X, and we want the 40. Well, everybody wants a 40, right? We want a perfect CO2. So we break this down. It goes to 7.2 times 52, 40X, 374.4 divided by 40. All this comes down to 9.36 minute ventilation. So now this is the patient not taking an extra breath at all. This is perfect in a bubble, but it's a good way to estimate what you want to change it to. Here's the cool part. Is we need to get a minute ventilation of that, but we can get it in many different ways. We can change rate, we can change tidal volume, we can change a little bit of rate, a little bit of tidal volume. So if you break this down, there's the answers. You can do all these different ones. So if you really want to get geeky with this stuff, you can look at exactly what rate and what tidal volume you would need. So if you need to decrease your tidal volume quite a bit, because maybe you're a little on the high end for their ideal body weight, you can do a tidal volume of 585, respiratory rate of 16, and have a really good answer for why somebody asked you why they went 585, because you did this calculation. So anyway, it's just something kind of neat to look at. Let's look at another one real quick. So we have 7.15, 90, 80, and 44. So obviously that is this is an interesting one because this is a partially compensated respiratory acidosis. Our bicarb's up, which that doesn't happen overnight. So this is a patient that's probably been hypoventilated for a long period of time. This is our COPD patient with an exacerbation. So we have assist control of 12, 700, 10 of PEEP, 50% FiO2. Their breathing, exhale tidal volume is 610. So we really can't count that 700 into the minute ventilation. We got to go with the 610. And they're satting fine at this point, but we're really concerned about ventilation. So what would you change? So in this case, they need to ventilate more, and we don't want to give them too much volume. So we probably would increase their respiratory rate by a certain amount. But the next thing that we're going to look at is, okay, we know how to do that now. We can go have and want, but what do we want with this? Because if we take this patient with a 44 bicarb and we put them at a 40 PaCO2, I mean, we're in trouble, right? They're going to be way metabolic alkalonic and their bicarb is going to say, what is going on? It's going to start holding on the hydrogen to take the bicarb down and all this other stuff. So we don't want to take them down to 40 because they haven't been at 40 for years. So there's a really cool formula you can do, which is my next most favorite, but it's very easy. Formulas you can do to figure what their target CO2 is in this case. And so in this case, the really high bicarb, let's figure this up. Oh, actually, I need somebody to figure this for me. So in this case, we have our bicarb was 44. So we take 44 times 1.5 plus 8. And I think I remember this. The answer to this is 74. That's our target CO2. So back on this patient, 74, we don't want to ventilate them down to 40. We want their CO2 to be 74 because at 74, they will be 7.40. And that's where they live every day. So that's why this equation is kind of cool because we're not just ventilating everybody back down to 40. This patient needs to go back down to 74 so that with the 74 and the 44 bicarb, it's evened out at 7.40. Math is fun. And then so that's called the Winner's equation. Just a little story about that. It's actually kind of cool. So during respiratory school, I was doing some clinicals at Terra Regional, and Dr. Tierdam, the late Dr. Tierdam, showed this calculation to me and said, "You'll never see this in respiratory school," and I never did. And it's been one of the coolest equations that I can kind of use and teach students coming up because they don't show you this. It's kind of a backwards way of doing the Henderson-Hausbach equation, but it really makes a lot of sense, and it's really easy to remember. So the last one that I have for today is a blood gas, and we're going to look at vent settings for this one. So we have a 7.25, a 60, an 80, and a 28. So this is another case of a partially compensated respiratory acidosis. You know, I'm a respiratory therapist. That's where I'm always going, respiratory acidosis. So we have a patient on SIMV of 10. And so a rate of 10, 700 tidal volume. We have a pressure support. I didn't put a pressure support in it, but I should have. Pressure support of 10 and a PEEP of 10 and an FiO2 of 50. So the current respiratory rate is 18. Their tidal volume, exhale tidal volume is 610, which is all right. You know, we have a leak somewhere, but that's okay. Vent usually compensates for that. The PEEP of 10, their SAT is fine. Minute ventilation is 8.6. And you're like, what does that mean? Well, that's the respiratory rate times tidal volume. That's the total. And their spontaneous tidal volume is 200. So in this case, this would be a patient that we have in a weaning mode that may not quite be ready for a weaning mode because we said that 10 mils per kilogram ideal body weight is 700. and their spontaneous breaths are only 200 per minute, or sorry, 200 mLs each time they take it. So they're either needing more assistance or they're not quite ready to wean yet any farther than where we are currently with SIMV. So in this case, with this, we would either increase their SIMV rate, so give them more set breaths per minute, more of those 700s per minute, or we could put them back into assist control until we get their blood gas under control, because you're not going to think about weaning anybody any extra when they go down and they start becoming respiratory acidotic on a ventilator. So those are just some different changes that we have. So I hope this was a little bit interesting today and maybe related a little bit to what you guys do. I know that there's not a lot of vent setting changes and whatnot, but I think that, you know, there's a good relationship between respiratory therapists and our paramedics, EMS crews, because we kind of think a lot in the same vein. So if you have any questions, there's no way to ask them right now, really. So, or is there?
They might be able to hear. You might be able to hear them if they ask.
And if you don't, that's totally
You can
cool.
always email me or email Jimmy.
That's right. And then interesting thing, I always plug my YouTube page at the end of this. So the cool thing about this, I just went over 14,000 subscribers, and I'll show you what my #1 videos are, and it'll blow your mind, because the stuff that we do every day that we close our eyes and do, people are wanting to learn this, and many people don't know. I got a message today from a guy who said, I was in medical school for 6 years and nobody showed me how to use a non-rebreather until I watched your video. It was just this morning. It was really cool. But if you look at the videos, I just want to show, I never showed anybody these before. It was really cool. My #1 video, and this is by views. So in the last 48 hours, I think I took this a couple days ago, but 601 views were for simple mask non-rebreather, 435 for Venturi mask, basic nebulizer therapy. I mean, it's so basic, like how to breathe, 404, oxygen therapy, nasal cannula, heated high flow cannula, that's a little specialty. Interosseous placement, that's kind of a cool thing. Using a flow meter 123 times in 2 days. So it's really cool. And you can see this is like 13 times non-rebreather got watched in 60 minutes. And the cool thing is only half of my viewers are in the United States. So there's universal language that we have among medics and respiratory therapists and nurses, and it's really delivering oxygen, because we all do it. We all have to do it at a certain time, and we've seen it done wrong ways and right ways. And so anyway, if you're interested, you can scan this and you can subscribe to me. So thanks, guys.
Thanks a lot, Jimmy. Much appreciated. Really good presentation. Thank you. All right, so I'm going to do a run review. So I was asked by a person or two, hey, you know, we always put some good runs up. You guys did a great job on this, great job on this. Did we ever have any bad runs? Well, this next run, I want to preface before I start doing anything and say, no matter what happened, the outcome for this patient would have never changed. No matter what, it had been God, would have been the only person that could have changed the outcome. Okay, the outcome was not good. The outcome included, was death. But there's nothing that anybody could have done differently. Period. It's as simple as that. Okay. That's right. Thanks. So, with that stated, I'm going to start with this. This is a 69-year-old male patient with a gunshot wound to the head. Okay. The service was, it's okay. So anyway, 69-year-old, I'm just going to leave it there. So we're not going to single anyone out, but this is something for everyone that can learn from. Anybody, doesn't make a difference. So the call came in at 10:47, dispatch at 48, en route at 49, on scene in 52. So they were there in 3 minutes. Left the scene at 58, immaculate, right? Probably the only thing we can take out of this run that was really, really good is the 6 minutes on scene time. They arrived at Union at 11:16. Okay, some more, so that kind of breaks that down. 5 minutes, arrival to scene from 911 call, 6 on scene, 29 minutes to get here. I need you to remember there were 29 minutes to get here, because that plays into part on some of the stuff we're going to discuss. So this following information actually came from the run report, the original run report. The original run report was not done well. It was vague, but it was just almost non-existent. The information that needed to be there. Jackie mentioned on hers, they didn't call in an IHERN in a really good time. Well, this happened on this run. There were some similarities to how this run went with the other one, except for I believe the other one had some more work done to the patient than what this one did. Okay, so the original run report said that the incident was at a location was a residence, handgun discharge. It was undetermined if it was intent, which means was it intentional or not intentional, right? This, when they got there, skin clammy and pale, and their mental status was unresponsive. Well, one would think that, right? That's simple as that. The procedures that were attempted, they attempted an intubation ×2 without success. The IO was unsuccessful. They did, the medic did get an IV, but that IV was gotten actually as they pulled into the parking lot. They did bag this patient, which was a successful thing, which was good. Initial vital signs, they were bradycardic. Imagine that, right? At a BP of 49/31, respiratory rate of 8, GCS is 3. 10 minutes later,
Copy paste.
yeah, the numbers didn't change. They increased the respiratory rate to 10, and I'm having to believe that's just because they were bagging them at 10, not necessarily anything else, okay? I have a hard time believing that the numbers stayed the same in a 10-minute time with a gunshot wound to the head. In the narrative, they were dispatched to a residence, complaining of a gunshot wound to the head. Upon arrival, they found the patient on the floor, supine, bleeding from both temporal lobes, okay? Obvious entries and exit wounds in the temporal lobe. Now, 101 tells you we don't ever describe entrance and exit. We just describe 2 holes. Our job is to plug those holes. That's literally what it is. It has nothing to do with describing. I mean, Dr. Malama was telling me the other day that it's just something that they learned even in medical school. It's just not something you do. Bleeding at that time when they showed up was not controlled. He did have, this particular patient did have shallow respirations, skin very pale. Patient airway was bloody, and patient transferred to a stretcher via draw sheet off the floor and exited. Again, 6-minute scene time, which is probably the best thing they could have ever done. More with they suctioned with a Yankauer, fireman asked to drive, patient transported emergent to Union. Intubation ×2 without success. They did bag at 100%, okay? Patient had a pulse throughout transport. Respirations were very shallow. Patient attached to the monitor did show a sinus brady. Systolic 50s noted. It was a little bit below 50s when it was there. IO attempted was failed. The IO was placed. I believe the medic didn't like the placement. It wasn't secure enough, so he did not use it. They did obtain an IV in the left AC with a 20 gauge, but that was also after a couple of attempts, if I'm not mistaken. So, all right. So information that was given to the ER at the time, this is in the run sheet. This is actually in the run sheet too. Yeah, but they also talked about this when they did that. Although the IV access was obtained, I did not give any fluids or drugs for low BP to start fluids. And I'm going to stop here, and I have to ask why. And I'm sure a lot of you are looking at this and maybe thinking to yourself, why would that happen? And we have a gunshot wound to the head with 2 holes. First of all, we elected to bring this run in. I'm going to start there, to bring this run in. So we're bringing the run in. If we elect to bring the run in, we have to do more than what has been done. Okay. So they finally get an IV. They did not take time to at least put fluids on. Even if it's in the back, if they just pulled in to the hospital, they just put it on a saline lock. That's all they did. No fluids, no nothing. Okay. Because the patient was at the hospital, the patient began to code just as the patient was transferred. Hospital only worked this patient 7 minutes and they called it. I'm not so sure it actually went 7, as Jackie said, but anyway. So I'm going to talk about this one in length because I think this one is really, really, really tough. IHERN. IHERN was given 10 minutes out, and all it said was a gunshot wound to the head. I got to listen to the IHERN. Jackie listened to the IHERN. And we're 10 minutes out. We're coming into your facility with a gunshot wound to the head. Literally, that was all the information. When they were asked questions, they didn't answer. They didn't respond. All right. So the crew is taking care of this patient. Well, the crew is bringing this patient in. Let me rephrase that. They call in again. We're 2 minutes out. And no further information given. So the person that takes the IHERN asks for kind of patient demographics, advised the gender and an approximate age, which wasn't even close. They did have the male port right. That was about what they had. RN asked if this was self-inflicted, and they didn't know, which is, to me, means they got zero information at the scene. They took no time to find out any information. Someone, even if it's not the paramedic could have directed someone, I need as much information as I can get right now. I've got a male patient with 2 holes in their head, right? And so I need information as best as I can. They didn't bring any information with them. And it's going to be evident in a little bit when I start talking to you about the arrival to the hospital and how the conversation did and did not go. So with what limited information we had, the level 1 trauma was activated. The 60-second timeout started, but it did not get finished, and that was something that Jackie was going to talk about.
He actually walked out.
Yeah.
If you can hear me, the medic actually walked out when the charge nurse was trying to do the 60 seconds.
Yeah, and they had to stop the medic and pull him back into the ER, back into the trauma room. Okay, so they stated that the patient was found in a work garage. They did have pulses when they were coming to here. They started CPR at 11:17. 1 round of epi was given. The ultrasound showed no cardiac activity, PEA. Pupils were fixed and dilated. Time of death was called at 11:22. So that's literally only 5 minutes later. So, and when I say, before I go on, I'm going to say Jackie was there. I was not there, but I got some great information from her. And then this run is something we have to learn from. The paramedic came in, and the first question, he started to leave, and they had to stop him and say, hey, they're going to have questions for him. The trauma surgeon was in there, and the ER doc was in there, and questions were started to ask, and the answers were, I don't know. Well, where would he find him? I don't know. I would think maybe at his work. Well, why? Well, because there were tools laying around. You know, I mean, that could have been anywhere, guys, honestly, right? So he was unaware of what happened. The answer question was it self-inflicted? I don't know. You're going to have to ask the deputy. And that was mentioned probably multiple times. You're going to have to ask the deputy. You're going to have to ask the deputy. Guys, we cannot bring a patient to any facility. I don't care if it's Union. I don't care if you take them to Methodist, you're going to get ate up. I mean, just an amazing, just something to learn from. You got to get that information. Not only could the paramedic, and not only the once again, didn't change the outcome. I got to throw that out, but no information was brought. We can't paint a picture. We can't let them know what's going on. Should we have worked it 5 more minutes? No, not at all. But that's not the point. If I could have given you every piece of information, doesn't change the outcome. But the medic gave nothing. I mean, he had nothing to offer, which does no good for the trauma surgeon, nor does it do any good for the ER or the nurses there who are trying to help and trying to give this patient the best chance they possibly can. And it's just really disappointing when we went. And the only reason I'm bringing this up is specifically because it needed to be brought up. It needed to be something we can learn from. So it was brought up to the service director and vice president, and the paramedic was talked to about the run report, and the paramedic did do an addendum. Okay. In the addendum, it stated the medic went directly to the patient. Media evaluation showed an entrance wound above the right ear, an obvious exit wound on the left side. Brain matter was present. Patient presented very pale in color. Did have obvious respirations, which I could see with the rise and fall of the chest. Additionally, immediately noted that the airway is full of blood, caused him to have gurgling respirations. The cot was being unloaded near the patient, so the decision to move the patient to the cot and to the truck to secure the airway was made. And I kudos to that. That was a good decision. They've got to get an airway controlled, right? No chance at all, probably no chance anyway, but if they've got any chance, it's got to have an airway. Patient was moved from the floor via blanket and taken to the ambulance. Immediately suction, the ambulance was used. Suction had to come multiple times throughout this thing. The blood was just filling up, okay? En route to the Union was driven in by a volunteer firefighter. Due to excess blood airway, suction several times, cleared the airway enough to be able to visualize and attempt intubation using a MAC and a 7.5, however, not able to visualize the cords. Okay, so, and that is a distinct possibility. All right, so they attempted it 2 times and was unsuccessful. And so they went with the bag valve mask at 15 liters. I believe they were getting good rise and fall in the chest, and that was moving air. Probably moving lots of blood around, but still moving air. There's not a lot you can do about that. Still had a pulse with shallow respirations, meaning the patient was actually still trying to do their work. The firefighter that accompanied us to the hospital bagged the patient while I attempted to secure. So we had a paramedic, a volunteer in the back, a volunteer firefighter driving, and we had an EMT. I've yet to figure out exactly what the EMT was doing. I do know the EMT was the one that called the IHERN in because she was the female and it was a female that called the IHERN in. She didn't have any information to give on the IHERN other than, hey, we're 2 minutes out. And now, you know, luckily I'll give them at least somebody called 10 minutes ahead. If you go back to that burn thing, 1 minute. Oh, by the way, I've got two people, multiple, blah, blah, blah. So, you know, if you can get on the IHERN, call on the phone, do whatever you can as soon as possible. If you call on the phone, it's still a recorded line, so we can still read it and listen to it. So just remember that's something to be important. The attempt at the IO in the left lower leg, this is still in the addendum, by the way, okay? Did not secure, was not comfortable with the placement, so established an IV. A 20 gauge in the left AC. All right, so if that's what they can get, that's what they can get. But what I have a real problem with is we had a 29-minute transport time, and we could not, I mean, it didn't show, I think, was there two IV attempts and it got the second one? But that means they didn't get the second one, though, until they were almost pulling into the back of the ER, okay? The IV attached was a saline lock. No fluids, no anything. I mean, they could have hung it to a bag at a minimum and run it full blown. They could have hung it at a bag. So arrived at the hospital before the other patient care could be accomplished. Again, there were 18 minutes. There could have been, I mean, we're here to learn, right? There should have been a whole lot more done for that patient in an 18-minute time. I understand it's hectic, man. We've all been there. I understand that there's problems there. I'm just trying to educate everybody and try to hope that we can all learn. I learned something from this run. Jackie and I both talked about how much this run could be, people can learn from. And I just wanted to bring it to everyone's attention. He was being bagged the entire time, which is a great thing. Great thing. There's probably, like I said, guys, nothing changes the outcome of this patient. But the care given was way subpar. And the service understands that, and so that was something that they were dealing with on their end. Patient still had a pulse and shallow respirations, but assisted with the BVM to the cot, to the bed, transferred care, and that's how the end of the addendum was written. As you saw, they only decoded the patient for 5 minutes. With the brain matter showing, the problem he ran into was he had pulses, and I'm not, you know, and I don't know if he had good solid pulses or if it was the paramedics feeling his own pulse when he was taking the pulse. You know, you just don't know. So we understand it. But also, I do have to say, this particular service does not work under the Vigo County protocols. So their protocols, I haven't seen them and don't really need to, honestly, because we have nothing to do with this service as far as any control over them. We did have an opportunity, if necessary, that our medical director could talk to their medical director, but their medical director stepped up to the plate on this one, and they have handled some situations. They've handled the situation pretty well. I just need to get some more information to close the loop. But so that's all I've got for this run. I just think that, you know, I think the problem is the only good thing I can get out of it was the scene time, the decision to move. There were multiple places for improvement here. Please understand, grab as many hands as you can. Anybody on scene can get information from you. It does not have to be a medic. And I would say that the problem is saying you'll have to ask the deputy. The deputy was intimately involved with this patient. Okay, so that was not a good answer. It just was not good. Okay, so
and there were 3 people in the back of that ambulance.
Yeah, 3 people in the back of the ambulance and the driver, and we got next to nothing. Oh, I mean, literally next to nothing for information. So just something to keep in mind, something that we can learn from. If I get these kind of runs again, I'm going to do them again and again and again, so we can all learn from them. And if we get the good ones, we're going to put them up there too, because we got to do kudos, but we also got to hold ourselves accountable. And this particular run was not handled well at all, at a level where we should have been as EMS professionals out in the field. So
I think it's easy to think that the 60 seconds is just a checkbox for trauma. It's not. It's for you guys. It's the opportunity for you to have to tell your story one time to everyone. That way, everybody gets the same story. Everybody gets the facts because it came straight from you. And so this one, we couldn't even. I was telling you, I stepped in front of him to keep you from stepping out of the room.
Yeah, I mean, he didn't have any information, so he wasn't going to stand there and be questioned because he didn't know the answers. You know, so then that's it. And we know that the 60-second, we're working on that on a daily basis whenever it's coming in. You know, I've got some feedback on some people. Sometimes it does it, sometimes it doesn't. We're working on that point
And
of
I
it,
need
okay?
you to be honest with that, because every level one, I will send an email to whoever the director is, who then turns around and sends it to the crew, and the crews are coming back flowers and sunshine.
Yeah,
It's great, everybody did what they were supposed to do, when I know for a fact it's not happening all the time.
And if it is not, please let us know, because we cannot get better. We cannot make that. I mean, that is, that was a contention in 2020 as one of our, as a goal, and we're working, and I'm sure it's just going to carry over now, and we're just trying to be the best we can possibly be as a trauma center for you guys, so that when you bring your patients, that you feel comfortable being able to tell your story in 60 seconds when everyone's quiet and listening. All right. And if they're not doing that, tell them to be quiet. Say, I want to get my story, listen, and then let them tell you. Okay.
And I think you need to remember that your documentation is your safety net. So had this not been a self-inflicted gunshot wound, maybe we found out later that it was a homicide.
Yeah.
That's not going to go to court tomorrow. That's going to go to court 3, 4, 5 years from now. And that piece of paper or that documentation is what you're going to have to go back and go, oh, okay. Because you can say it. Those of us that have been in court knows this. You can say, well, I distinctly remember, and they're going to look at you and go, but it's not in your report.
Yeah. You didn't write it down. Didn't happen. Right. So simple as that. So if you have anybody any questions, they can send to me really quick or talk to me. That's fine. If not, that's all we've got for today. Please be sure and email me that your name that you were watching, or have your EMS service, your director, send me all the names of people that were on today. So I want to make sure I get them on the agenda, on the attendance. Say thank you very much. Jimmy, Beth, Jackie, everybody. Thank you so much for the presentation. I appreciate it a ton. So guys, have a good week, and we'll see you next month at regional. Also remember, next month is EMS week. We'll be having our EMS cookout at Union Hospital on May 19th at 11 o'clock. It'll be from 11 to 2. We'll be providing Rick's Smokehouse again, as usual, box lunches. The mayor will be here to do our EMS proclamation at about 11:30. Love to see everybody there. Get as many people as we can. We'll be outside under the tent, social distance. We'll be doing what we need to do, but we need to have a good representation so we can show that you guys deserve what you get out there in the field. So thanks a lot. Appreciate it. Have a good day.
The sheriff's deputy with his son.
Oh, no.
The son had gone, he had just found out he had cancer the day before, and so he was basically given up. And